Hey everybody, Mrs. Castro here. We are going to finish up our last exemplar. We were able to get through the rest of mitral valve prolapse. Pretty straightforward, that exemplar last night. And we went through PVD and CAD, so we just had to finish up Tetralogy of Fallot. If I am not able to finish it all up in this one video, then I will make another one, but I'm going to try to talk fast. So the name, tetralogy, tetra, think four. And we're just talking about, instead of talking about the pathophysiology, we're talking about tetralogy. So this four-fold problem of Fallot, and Fallot is just the physician that named it, a French physician. So what happens here, and if you've watched the other video that I provided for you, she also goes over this in pretty clear detail. But we have our normal heart on the left-hand side. We reviewed this yesterday about how blood flow goes through the heart. And we have our pulmonary artery carrying away our deoxygenated blood into the lungs, and then it returns into the left atrium through the left ventricle, and it goes out through the aorta here. So basically what's happening is four different defects that all occur simultaneously. There are lots of congenital heart defects that can occur. Usually you just have one or the other. In this case, there are specifically four that all occur together. So you have this ventricular septal defect. What that is we think septal, that's a wall. So that's referring to the septum here. Ventricular, that means it's between the ventricles. So there's a problem with the wall between the ventricles. There's a defect there. So what that means is there's a hole, and usually this hole occurs right up here, right nice and close to where the two ventricles do their pumping, one into the pulmonary artery and one out the aorta. So that's where that defect occurs. So we have a hole there. So normally there's wall, there's no wall there, there's a hole. Then you get this pulmonic stenosis, and what that refers to is this narrowing of this pulmonary valve. This is our pulmonary valve. You see how it's pretty big here in this left-hand one, and here it's half the size here. So we get this narrowing of this valve. So that means that the right ventricle, which normally is thinner, remember we looked at a picture last night where this wall was thinner and then this left ventricle wall is nice and thick because of this hard muscle that has to work really hard and push the blood out. Well, then this right ventricle ends up getting hypertrophy over time, which we see here. That doesn't occur just because, oh, it's just hypertrophied. It's from working so hard to try and pump the blood up here into the pulmonary artery, but that pulmonic stenosis makes it very difficult to do that. So that's a problem. We've got a little wall here, and then we have this pulmonic stenosis, and we've got this hypertrophy of the right ventricle because it's having to work a lot harder than it should. So if you want to think about maybe a weightlifter that maybe that's only lifting weights with one arm, then what's going to happen in that one arm? That one arm is going to get nice and defined because you're using it so much. So that's what's happening to this right ventricle. It's hypertrophied because of use. And then we have this overriding aorta. What does that mean? Well, normally, as you can see, the bottom of the aorta opens into the left ventricle here, but in this case, it's higher and it overrides and opens up into both the left atrium and the left ventricle. Remember that we said we have to have these chambers and the valves in between them to keep the correct pressures in the heart. So now we have this problem where it's in between the two chambers. So we have a pressure differential there, or lower pressure, because of the opening there. The aorta is getting blood from both the left atrium and the left ventricle. So they're not able to function like they normally would. And then on top of that, this overriding aorta normally occurs right over this septal defect. So not only do you have a problem with the pressures here and the valves that open and close in response to pressure, so we've got a pressure issue. Now we've got this happening right over this wall. Well, if you can imagine, it's so hard for the right ventricle to pump through this pulmonary stenosis, and if we have a little out here, then blood, this deoxygenated blood, begins to mix with the oxygenated blood of the lungs, and only partially oxygenated blood ends up getting pumped out. So this is pumping hard, and if the pressure here is higher than the pressure here, then this mixed blood picks up this mixed blood and it all goes out to the body. So basically the problem then, what we're going to see, is we're not going to have a functioning cardiopulmonary or cardiovascular system that's able to pump nutrients and oxygen, especially in this case oxygen, out to the rest of the body. So that's what's happening in Tetralogy of Fallot. Well, how does this happen? Well, the risk factors are all in the mother. Okay, so there's several ones. If the mother has German measles during pregnancy, any viral infections during pregnancy, age 40 or older, has diabetes during pregnancy, whether she was diabetic or she developed gestational diabetes, and it's also hereditary. So if you have a genetic predisposition or risk for Tetralogy of Fallot, then you're more predisposed to have this, for your child to develop Tetralogy of Fallot. So what happens then here? So what happens is baby comes out, and they might be acutely cyanotic at birth. And you might be thinking to yourself, well, why is this a problem here? Wouldn't we kind of know that this was going to happen, and we would have referred the mother on already to higher care and stuff? Well, you need to think about the fact that, especially here in Del Rio, we live, and in Eagle Pass, you live right on the border. You take care of individuals who come over from Mexico who may or may not have gotten good prenatal care, if any prenatal care, whether that's because of socioeconomic status or beliefs or the nature of the pregnancy, whether it was wanted or not wanted. A lot of those things can affect how the mom treats her pregnancy. So this is very relevant to where we live, because we need to be able to, as nurses, to recognize this and to make sure that we rapidly intervene and refer the baby to a higher level of care before there are life-threatening issues, which it's already technically a life-threatening issue, but before it progresses and worsens, because it's not sustainable. Life is not going to be sustainable after birth with the Tetralogy of Fallot with persistent hypoxemia. So, and hypoxemia just means low levels of oxygen in the blood. This also has hypoxia, which talks about just low level of oxygen in the tissues. So you have low oxygen blood levels, and of course if you have low levels in your blood, then it's only a small amount is going to get out to the tissues. So you have problems with hypoxemia and hypoxia here. And as you all know, without oxygen, life is not sustainable. So we need to intervene rapidly is my point. It is possible too, depending on the nature of the defects or how severe they are, that maybe the baby will not be acutely cyanotic at birth, but that means very blue right away. Maybe this will progress over the first year of life, and as the pulmonary stenosis worsens. So we may be able to, if we go back to our pressure differentials, if we don't have as much of a problem getting this stuff out here, then our right-sided hypertrophy might not be that bad, and we're still going to get some blood mixing, but this left ventricle is nice and strong, and if the pressure's low over here, then blood will there won't be as much mixing of the deoxygenated blood that's being pumped out. So it shouldn't be too, if those defects are not that bad, the septal defect, the hole in the wall isn't that big, and then our pulmonary stenosis isn't so bad, then we won't get quite as bad of that deoxygenated blood mixing with the oxygenated blood. But over time, as the heart has to work harder and harder, our pulmonary stenosis will increase, which will increase the hypertrophy, which will increase the mixing of the blood, and will increase the clinical manifestations of cyanosis. So how do these patients manifest themselves? Okay, so they may be acutely cyanotic at birth. We may have a progressive cyanosis. They will have a very characteristic systolic murmur that you will hear. So you're going to hear this murmur during systole, the systolic phase of when the ventricles. Remember, that's what the systolic measures, is the force or the pressure present during systole when we're pushing out all the blood into systemic circulation. And then they have these very particular Tet spells. Okay, so these Tet spells, look at, we have all these manifestations. These are manifestations of hypoxia. Hypoxemia is the low oxygen in the blood, and it's first seen furthest away from the heart. These are the areas furthest away from the heart here, where we have the thinnest amount of capillary beds. So that's where you're going to see these manifest themselves as much here. These Tet spells, these blue on the baby. So you might notice those, whether that's acute happening or whether it worsens here. So these Tet spells are extremely characteristic of this. And then you have these anoxic spells, which means that there's no oxygen happening at all. And that, again, leads to this, and this happens during crying or feeding, because again, we're increasing the oxygen demand, and then when crying, we're not. If we were to cry, remember how I don't know the last time you cried, but you kind of took those gasping breaths, those little like that, and we hyperventilate a little bit because we're trying to get some more oxygen in there, so, and blow off that CO2 that's been retained by us not breathing because we were busy crying. Same thing with us eating. In any kind of respiratory disorder where we're occupying our mouths to do something other than breathe, then you're going to have a kind of mismatch as far as your oxygen demand increases, because all of a sudden we've kind of stop breathing as much. And normally we can compensate okay for that. We breathe through our nose, or we naturally pause during feeding while we're eating. But in babies, this is a severe, they are severely affected by this, by feeding and crying. And then right to left shunt just refers to, again, the pressure differential. If the pressure differential is higher in the right ventricle, then you're going to see this right to left shunt. And I know that it's weird because on the screen you're like, that's not right to left, that's left to right. But it's from the right side to the left side of the heart. So right to left shunt. And then again, remember, we said if it's not so bad, the pulmonary stenosis, then you'll see a left to right shunt. So that's that's what this shunt thing means. So what does this put the baby at risk for? Well, because of how long the blood can stay and hang out in the heart. And remember, anytime that blood is kind of sitting there and it's not moving around, it's going to start clotting, because that's just what it does. So, when you draw labs, I don't know if you've ever noticed that in the bottom of the lab tube, there's already a little bit of heparin in there. And that's to keep the blood from clotting off while you send it to the lab for testing, because blood, once you draw it, naturally starts clotting. So as it sits there in the heart and it's not being moved through it as fast and as it normally would, it puts them at risk for emboli. And then anoxic seizures just from not having any oxygen to the brain, and again, loss of consciousness, no oxygen to the brain there. So we've looked at that already. So I'm quite the talker, so we're only at, I use a free screen sharing program that only allows me 15 minutes per video. So I'm going to end this one there with just the clinical manifestations. So we reviewed the heart, we reviewed these clinical manifestations and what's actually going on inside of the heart when we see these clinical manifestations. And we'll get into assessment. I think that you can probably make some guesses already about that, but we'll get into that in just a second here, okay?